we have successes to learn from. We also have new products coming to the market, which do not just represent new products, but really represent a paradigm shift to choice, where we finally may have the options that could suit someone's preferences and lifestyle over time. There's also a greater focus on prevention than ever before, in part because we are lagging behind on these targets and have not seen anywhere near the progress globally that we've seen against the 95 targets. The Global Fund has a focus on HIV prevention in their latest strategy that we've never seen before. Similarly, we've seen greater prioritization by PEPFAR, other governments, and other payers. We're at a really important point in the HIV response to take stock of what we've learned, to move into the future of prevention, taking evidence-based approaches, guided by the voices and perspectives of communities, which you will hear more about today. So without further ado, I will first introduce you to Lysias Zembe, a medical virologist and advisor at UNAIDS with decades of experience in VMMC and other HIV prevention interventions. Thank you.
Thank you, Dani. Yes, Dani highlighted, my name is Lysias. I'm based in Geneva. I work at UNAIDS. I'm the VMMC/Men and Boys focal person. As you know, recently we're trying to broaden our approach to men and HIV to provide broader health service and not just focusing on the VMMC. I'm going to provide a quick snapshot of progress that has happened in implementing the VMMC program for the last more than 13 years now. And I've always said, especially recently when people are discussing sustainability, that VMMC is a very, very good example, HIV prevention program to learn from how it has been implemented. Some of its success has been also a cause for its drawback in terms of how it started as a vertical program. And now they push into sustainability or discuss sustainability. But this is one of the programs where we started discussing sustainability long time ago, and we've looked at sustainability as a specific program, which should be the case that sustainability discussions should go beyond the finance. There are a lot of programmatic aspects that needs to be taken into consideration when discussing sustainability. That goes beyond the money. Next slide. So to begin with, I think this is the bottom line. There's been a lot of modeling work happening recently that are feeding into sustainability discussions to look into what interventions are effective. The bottom line, and this is a fact, VMMC remains the best buy for HIV prevention at the moment. You put in your money, you get the impact, and there's no other intervention that gives you that cost effectiveness, even cost savings in some settings, even settings where there's low HIV incidence. And we know VMMC reduces the risk of acquiring HIV of men by 60%. And this is a once-off thing that you don't have to keep on doing to a person. You get it once, it's done. So I think this is one thing that we really need to keep into consideration. Recent modeling work that is being done, it keeps on showing that VMMC is cost-effective. In some settings, it's even cost-saving. So this is what we need to keep in mind as we discuss sustainability discussions of different HIV interventions. But what is sustainability? I think I'm going to go back to looking at what has happened in the VMC program and what could be some lessons we can learn as we discuss sustainability. First of all, I think we need to have an idea about what sustainability is. Different people coming from different backgrounds, they've got different ideas of what sustainability is and what it should be. Basically, it is the capacity of a program to consistently and effectively address the HIV epidemic over the long term. There are aspects of sustainability that should be taken into consideration when you look at an intervention: adaptability, the ability to change. Remember, we're dealing with an ever-changing virus. Our interventions should be able to adapt to the ever-changing HIV epidemic. A sustainable HIV prevention intervention not only achieves the short-term impact, but it should also ensure lasting changes by fostering community engagement, mobilizing resources, and also building local capacity and advocating for supportive policies. If you combine all these, then you're talking about sustainability for whatever intervention you are discussing. When you look at VMMC, the idea of sustainability has been there for a long time now. We know that since 2007, when the program was launched from the UNAIDS and WHO recommendations, which then expanded onto to date, there's been a lot of progress. Countries scaling up VMMC, countries focusing on different aspects, focusing on funding, focusing on different service delivery models, also focusing on ensuring how to innovate around demand creation. So the thinking has been there in the program, but how it has been implemented as a vertical program, maybe that is what has been its drawback if you want to discuss sustainability in the context of the program. But how did we get here? I think it's good to have an idea about the evolution, this whole evolution of the VMMC program. So first, there were these studies, right, that led to the recommendation of VMMC as a cost-effective program. A lot of meta-analysis was done, a study of randomized control trials done, and this led to recommending VMMC as an HIV prevention intervention in areas of high HIV incidence in 2007. And then that recommendation that was issued by WHO and UNAIDS, which was the first one. Then there was also translation of the WHO, these recommendations, WHO guidelines into national policies. So all countries, they translated these WHO recommendations and guidelines into their own specific national policies to suit their own context to scale up VMMC as an HIV prevention intervention. And then since 2009 up to now, many countries have been scaling up, different countries reaching different levels of coverages. If you look at this and now trying to put it in the context of sustainability, the timeline, this is what you get from 2005 to 2007, where the findings were made around the randomized trials to recommend VMC as in HIV prevention intervention, recommendations being made, and then 2011, a joint strategic action framework for accelerating circumcision was launched by WHO. And then 2012 up to 2016, we saw a huge scale up of the program. Countries focusing on different models of delivery, be it mobile clinics, being fixed sites, and also innovating around demand creation strategies to increase accessibility of the intervention. And then in 2021, a framework was launched by UNAIDS and WHO on VMMC. In this framework, it already incorporated an aspect of sustainability and also an aspect of broadening the intervention to include broader health services for adolescent boys and men. And then all this framing and thinking, this is what it gave result to. This chart, which Dan has already shown in your introductory remarks, this is what has happened over the time since 2008 up to 2022, which is the latest data that we have when the countries report to UNAIDS. We can see the increase as countries were getting more resources, as countries were innovating around demand creation. We saw in 2015, 2016, when the tetanus issue happened, a drop in VMMC scale-up, and then an influx of resources after that led to that huge scale-up in 2017, 2018, 2019, and then COVID happened. We see a drop, and since then, countries haven't really recovered also from that for different reasons beyond just the COVID issue. When you translate these numbers into coverages, as you know, the global targets, coverage targets, the targets to reach 90% coverage of adolescent boys and men in those 15 countries of high HIV prevalence. These three maps are just showing VMMC coverage at the national level, at admin level 1, which could be a provincial level depending on what each country calls it, and the level 2, which is usually the district level, and some countries call it something else different. But what we can see from here is the national level can give a picture, say, okay, there seem to be high coverage of VMMC to date now. But when you drill down to the sub-national level, be it provincial or district level, we can see there are other districts, quite a number of them, where coverage is still very, very low, and these are areas that needs improvement. What has been the lessons from VMMC that we need to consider when you look into sustainability? Remember, in my definition of sustainability, there was an aspect of funding, there was an aspect of how you focus our programs to target, there was an aspect of advocacy, there was also an aspect of how you prioritize interventions, making them adaptable to the ever-changing epidemic, making use of science and also demand creation to make sure that we reach high coverages of the program. So when you look at these aspects and you look into VMMC is one of the programs that really got dedicated funding. And we know the main donor for this program has been PEPFAR since then, even up to now, with some limited domestic resources from in other countries. So there was a lot of influx of resources from PEPFAR in terms of the funding, and this helped the program to scale up. There was also a lot of use of data, like VMMC used quite a lot of data. Of course, there were challenges in terms of how the data was collected, how it was being monitored, but there was use of data to inform targets for the program. And also, there was quality monitoring that was put in place to make sure that the intervention is safe and acceptable and is providing quality services to those accepting the program. Demand creation was a big thing when it comes to VMMC. A lot of money was being put, private-public partnerships were being established to try and innovate and understand men. As we know, there's been challenges in terms of reaching men or making men access HIV services. A lot went into demand creation for VMMC as a program. And all these aspects are very important when you're trying to define sustainability over time. Looking at funding, 2.9 billion cumulative since 2007 has been put by PEPFAR alone for VMMC. This is a huge amount of money. If you're talking about sustainability, you need to make sure that funding is there for that intervention to be able to be implemented. When you then try to sum it up, this slide is just trying to pull those different elements and then in the context of VMMC. Adequate resourcing, we see the 2.9 billion that PEPFAR put in since 2007 towards the intervention. Data to inform targets, advocates, and funding as well. The art and science of demand creation, we see these at play in the implementation of the program. Also prioritizing quality and safety, which ensures that the intervention is safe and is acceptable, and also engaging the community, which makes an intervention sustainable over time. For other interventions, this is the balance, especially when you look at the demand and supply side of things, something to really consider if you're thinking sustainability for other HIV interventions. On the demand side, mobilization is important, engaging communities is important, campaigns, making sure that people are educated to understand the intervention. That makes the community accept interventions and making it more sustainable. And then on the supply side, making services available closer to those who need it, focusing on providers, making sure they are educated to provide quality services, differentiating, making sure that people are not the same, people are different, focusing on quality, and then in the context of MMC, broadening to men's health services, make sure that services are integrated, they're not just providing one specific service, but broader services that provide a holistic approach to addressing what you're addressing. So these are lessons we have learned from VMMC. Some of its successes have been its drawbacks. For example, its implementation as a vertical program has been its drawback, although it was very successful because it then received very dedicated attention with specialized people, logged in funding, which helped it to be very successful in its implementation. It is the only HIV prevention intervention that reached maybe 80% of its targets by 2020. When you look at the fast track targets, those 2020 targets, the MMC only is the one that reached 80% of those targets. Other interventions, they were even less than 50%. So that success was because how it was implemented as a vertical program, receiving dedicated support. But then it was its drawback when we want to look now at sustainability, because sustainable programs, they need to be integrated, they need to be provided in the context of other services. But there's a lot we can learn still in terms of how it was implemented. So basically, in terms of the elements that we can learn, either it was a success from VMMC or it was something we observed as a shortfall in the implementation of the program. An integrated approach to health systems and strengthening, very important, community engagement and stakeholder involvement, where we've got support from different stakeholders for that intervention. Data-driven decision-making, scalability through innovation and adaptability, a sustainable intervention to be able to adapt to the ever-changing epidemic, and different financial models for long-term viability. For VMMC, it has only been mainly paid for supporting it, but for sustainable programs, we know that we need different financial models that can help the long-term viability of that intervention. That's all I had for now, and I'm happy to answer any questions. Thank you.
Thanks so much, Lysias, and what an excellent presentation demonstrating that we have the systems to deliver prevention at scale. So now we're going out of order in products, people, products, and systems. From systems, we'll move to Dr. Tina Chisenga, who is a public health specialist and currently the Assistant Director in Infectious Diseases in the Zambia Ministry of Health. We will be moving on to products to talk about CAB-LA introduction and kind of the new frontier of HIV prevention. Thanks so much, Lysias. And over to you, Dr. Tina.
Thank you so much, Dania, and good morning, everyone. So I'm going to share with you the newest block on the newest kid on the block, and that is injectable pre-exposure prophylaxis. I know that most of your countries have different interventions when it comes to prevention, a different package altogether. So VMMC has been shared. We have the condom programming, and we also have social behavioral change communication still going on in our countries. And we did, obviously, we're excited about oral pre-exposure prophylaxis, but currently not all of us, but some of the countries are trying to introduce the injectable pre-exposure prophylaxis. And I'm going to share with you some insights from Zambia. Okay. Oops. Yeah. I think maybe you can change the slides for me. So just to give a brief background of how we have fared in terms of the oral pre-exposure prophylaxis in our country, we introduced oral pre-exposure prophylaxis in Zambia in 2017, and this has rapidly expanded over the years. We started with only 4 sites and 116 clients initiated on PrEP, and we have moved through the years. As of 2022, we have over 1,600 sites and had initiated 150,000 people on PrEP as of end of 2022. And end of this year, I know for sure that we're initiated at least over 200,000 people on PrEP. Next slide, please. So in terms of some of the challenges that we've noted when it comes to daily oral PrEP and showing some signs of how injectable PrEP can be used to mitigate some of those challenges. We have noted some low adherence and low continuation rates when it comes to oral PrEP. Some of the continuation rates as of 12 months as low as 11% in some of the sites. And we have also noted a few seroconversions because of the low adherence. And because of the low adherence, this has led to low protection and, of course, seroconversion of some clients who are on oral PrEP. One of the things we've noted is the daily pill burden that comes with oral PrEP implementation, and this has really affected how we're implementing our program. In some of the sites, you actually note that when clients collect their oral PrEP, at the back of the facility, they have discarded their bottles and put the pills in a little sachet. So the noise that the bottles make is actually an issue for the clients. And so we've noted that some of these challenges that we have seen can actually be mitigated by the introduction of injectable PrEP. For instance, the frequent dosing is reduced, so that actually improves adherence and continuation. We also note that based on the information that has come through the studies, that the comparison between oral and injectable PrEP makes injectable PrEP at least 90% better than the oral PrEP. This does not mean that the oral PrEP is not effective. It's just that one, the studies were not done against the placebo, they were done against oral PrEP, but it also shows that because of adherence, it makes it more effective in terms of reduced new infections when a client uses it. The long acting also makes it easy for dosing, because there's no daily dosing. There's injection every 2 months, so that makes it easier. And of course, I mentioned the pills that are making noise when they're collected. So this is very discreet when someone actually has an injection rather than the oral PrEP. Next slide, please. So what we've done as a country, we did have a number of studies that were done within our communities, so as to better understand the way we're going to implement injectable PrEP. I'll give an example of a survey that we conducted with the support of USAID, and it showed that there is high acceptability compared to the daily oral pills. We've also noticed that people are looking forward to the fact that it's private and it's convenient, and they are also excited about the fact that they'll be able to follow through with being on injectable PrEP than on oral PrEP, because they'll be more adherent to their scheduled appointments, and they'll be able to make sure that they're getting the injection when they're supposed to have the injection. I think some of the things that have come through in terms of the fears of what injectable PrEP introduction is going to bring is the issue of the injection site pain, and also especially for the men, they were a bit worried about exposing their bodies to the healthcare workers. Further, we did have value chain situation analysis that highlighted that there is a demand for injectable PrEP, cabotegravir long-acting, and the clients are already asking for the injectable PrEP in our country. Leveraging off of the existing oral PrEP, we know that by the introduction of the injectable PrEP, we are going to reach all those that really want to have access to pre-exposure prophylaxis. Next slide, please. So Zambia was lucky to be one of the 5 countries that are going to be supported by PEPFAR in terms of commodities. And this was shared. This news was shared with us in March at the end of the COP planning this year. And we quickly went ahead and started thinking around how we were going to implement injectable PrEP. And our approach has been evident up with an eligibility criteria. So in as much as PEPFAR is going to support us with the commodity is not enough for us to go full scale within the country. We're only going to get in the first phase commodity enough to reach 2,000 people for a whole year. So based on that fact, we actually chose specific sites that have got very good oral PrEP implementation. They have good follow-up of all their clients, and they're also high volume sites. So based on that fact, we still thought this is going to be a bit difficult for us in terms of spreading the commodity around. So we came up with an eligibility criteria, which is a focus on those aged between 16 to 24. And of course, these people have to have a very high risk of HIV. And so therefore, we're considering intersectionalities such as sex work or men who have sex with men. Next slide. So the initial phase for CAB introduction is going to actually inform best practices and how we're going to scale up. So what we've done as next steps, or what we hope to do in the next steps, we were hoping that we would have had the commodity by now. So what we've done as a country, we have come up with an implementation plan that explains exactly what our eligibility criteria is, which sites we're focusing on, and also how ready the sites are need to be in terms of follow-up of all the clients that they're going to enroll in on injectable PrEP. So after the implementation plan was developed, we have incorporated injectable PrEP within our national PrEP and PEP guidelines, and this is going to be launched the first quarter of next year. And we have had a training of trainers. We had a regional training of trainers that trained Ministry of Health staff as well as some of our partners. And then we have, as Ministry of Health, trained our specific healthcare workers who are in charge of those sites that I mentioned, where we're going to have the first phase of implementation. We have formed a multi-sectoral CAB LA steering committee that is chaired by the Ministry of Health and coordinated by the National AIDS Council. We are still expectant of our commodity. So in terms of readiness as a country, we are ready. We're just waiting for the commodity to reach the country, and we're working alongside PEPFAR to make sure that the commodity is in country and ready for implementation by January 1st. In terms of monitoring tools, we have come up with some tools that are going to help us make sure that we track uptake, fidelity, acceptability, tolerability, discontinuation, and adverse events. Next slide. I think that's the last slide. Yes, thank you. Thank you so much.
Thanks so much, Dr. Tina. And I know everyone is so excited to see that some of the earliest evidence on CAB-LA implementation will be coming out from Zambia. So I'm sure we'll have many more exciting future presentations to see what rollout is like. And I know there are many, many countries who are really interested in learning from Zambia's experience. So now I'm going to turn it over to Janet Bila, who currently coordinates Zimbabwe Young Positives. She has extensive experience working with adolescent girls and young women, has served on as the National Programs Officer for the Development Agenda for Girls and Women in Africa Network, DAWA, and she's going to provide a community perspective on needs in the HIV prevention space. So over to you, Janet, and thanks so much.
Thank you, Danny. Morning, everyone. So my task really is just to deliver on the pathway for effective community engagement. And to do that, next slide, we are going to look at a number of gaps and opportunities within the HTS space. So there are persistent disparities really in terms of coverage for testing, where a lot of strategies are not effectively serving many priority populations. So, for example, we're speaking about men earlier on. We're also speaking about young people who may not be able to then freely access HTS depending on how or where they are getting the HTS service from. And services must be client-centered. For example, again, going back to men, where most of them are working an 8 to 5 shift and won't be able to get access to the clinics. How do we program around that so that they can be able to also access the services? And then also centering client voices is also critical to ensure that testing priorities and strategies are ethical, human rights based, and having the approaches that are also speaking to ethical issues and human rights. Then we also talk about civil society organizations which have a wealth of experience and best practices in serving key and priority populations. But also, again, there's a lack of avenues in influencing also national decision-making around HTS. CHAI has, through the support of GATES, the DRIVE project that Dr. Tina just spoke about, which also has a theory of change which is grounded around strengthening critical components of national HTS systems, centering priority populations in HTS decision-making, which is a core element of strong, resilient, and national testing program. So CHAI has initiated community advisory boards within different countries that able to then address these gaps and drive community engagement in HTS. So the CAB is in Uganda, Malawi, Zambia, and Zimbabwe, and these are an independent entity which also work with an HTS CAB lead, who's also an independent contractor, to be able to then do the work within the countries in question. The CAB members, as highlighted, are people from communities who are from community organizations who also come up with their own work plans and to also be able to advance community priorities in respective to their country context. Next slide. So coming back to the host of ICASA Zimbabwe. So welcome to Zim, everyone. Country context, really, we've had interactions with people within the country and they've spoken about HTS and their priorities. The first thing that I really want to highlight is the best thing that we've ever had is to give people choice. So for example, having a blood-based or an oral-based choice of PrEP. Someone, for example, would be scared at the sight of blood, so they would rather just take the oral test. So we're happy about choice. And then we have also the potential to increase access to post-test services through prevention and treatment as well. Although, again, speaking of post-test services, there's a whole lot of people who have issues around the mental health aspects of then when they then access, when they then realize they have a positive test, how are they going to be able to be supported within that aspect, the quality of counseling that is going to be given, how is that going to be? So it's a benefit and also a barrier as well. Then it's also convenient and reduces stigma. I can take the test at home and no one judges me for taking that test. The issue may then arise when I want to present myself at the clinic and finding the nurse being my aunt, if that happens. And then it also enables community-based distributions to improve testing coverage and may support decentralized PrEP delivery. Barriers really is supply not meeting demand. The new dollar self-test, HIV self-test will also help meet demand, but also ministries need to really commit to the scale up. And then we also have low literacy and awareness currently around HIV self-test. So we need to also increase that. And also we may require more innovative approaches to support linkages to prevention, when used outside the clinic. Many countries have not updated the guidelines, and I'm happy Zambia mentioned that they're also working to update their guidelines on PrEP and PEP as well. Next slide. So beyond self-test, we also have more areas on HIV response that may be guided by HIV, by community perspectives, So the delivery models, for example, how do we get the self-tests? How do we get the PrEP within the communities? Do we have to train community cadres to distribute that? If we have Cabernet, for example, do we have to train community cadres to be able to administer that within the communities? And how would that look like? And also the counseling messaging around PrEP and PEP, like I mentioned before. What type of counseling are we giving? The quality of counseling, is it also covering mental health issues? And what type of counselors do we have within the facilities? Are we just having basic counselors? Do you have people who have a psychology background who then have a plan on how to sustainably support everyone who's living with HIV, or people who are negative and will really need to know their status or prevent themselves from HIV? And then also sensitization and demand generation strategies. How will those look like? What has worked and what do we need to do so that we can also have sustainable programs that are there? And what mechanism and support that needs to that are required to help end users with side effects? So on my ride here, the cab driver kept on asking, does this have side effects? Because I kind of pitched Cabernet on my way here. And then so she kept on asking, does it have side effects? And all I said was, everything has side effects. It's how you look at it and how you weigh your benefits more than the cons on everything that you're doing. And then lastly, how can prevention programs effectively support user choice in a growing portfolio of prevention options? Thank you.
Thanks so much, Janet, for all of those insights about what the CAB has done in testing, the priorities in HIV self-testing, and looking forward at some of the future priorities and needs in prevention space. So now for the next part of this session, we have a few minutes for questions from the audience, and then I will turn it over to my colleague Tatenda for some closing remarks. So any questions, please raise your hand and we can come around with a microphone. We can hand to maybe 2 or 3 questions at the same time, and then we'll cover those.
Thank you so much, the presenters, and the congratulations, Zambia and other countries that have gotten the Cabello A. I want to marry the 2 presentations Zambia and Zimbabwe. Zambia mentioned a lot about means of health and the NAC. I don't know what the role of the community is going to be in the presentation. Maybe it was time. And then the messaging. There is a lot of quest for Kabelo A. Isn't it going to affect the other intervention of oral prep? We really don't know how it works in real world. So we have to go slow and do the right messaging, especially even the STI and pregnancy prevention. Thank you. We are moving into integration. Thank you.
Okay. Thank you very much to the presenters. I'm Halima from Nigeria. My question goes to Zambia. During your presentation, you shared the benefits of Kabele against oral prep, and one of which stood out was adherence. And you had mentioned some challenges with people on prep being adherents. However, where you mentioned the selection criteria for those that will be enrolled in the study, adherence, non-adherence wasn't a criteria. Rather, you are going for people who were already quite adherent on prep. So I thought maybe you should consider those that have been on prep and dropped out.
Thanks so much. I think we'll take one more question and then we'll go back to our speakers.
Thank you. And thank you so much to all the presenters, really excellent presentations. My name is Esther. I'm from here, from Zimbabwe. My question is on VMMC. I know that it's been an initiative that has been really moved forward by PEPFAR, but I'm just wondering whether as governments, we want to think about infant male circumcision, because I know that PEPFAR wanted this done because they wanted to prevent HIV in people who are already starting to have sex or are already having sex. But as governments, should we not routinize or make circumcision routine in our infants and do it as soon as the baby is born, where it's much more, when it's easier and there are much less side effects? Thank you.
Thank you so much. So then maybe I'll turn to Lysias first on infant male circumcision, and then Dr. Tina on community engagement, how CAB will interact with other PrEP options, and then the CAB-LA eligibility and target populations. Over to you, Lysias.
Thanks, Dan, and thanks for the question from Zimbabwe. It's been a question that has been there for some time. You remember when VMMC started, there were a whole lot of discussions around the targeting, and there were discussions around infant male circumcision with UNICEF working closely with the WHO, leading on those discussions. And then later on, when the latest guidelines came from WHO, the latest guidelines and recommendations on VMMC, they looked into some of the safety data that highlighted some safety concerns in circumcising smaller or very young kids. And then those recommendations then led to recommending VMMC for the 15 plus age group, and then PEPFAR aligned to that age group. And apart from that as well, there were also modeling work done trying to see what could be the best investment now to achieve the 2030 goals. And then the recommendations were, let's focus on males who are at highest risk of acquiring HIV. So apart from the safety concerns, there was also to say, with the limited funding, what is the best use of the limited funding that we have to achieve the impact that we need within the 2030 goal of ending AIDS as a public health threat? And then it also pointed to focusing on adult males who are at highest risk of acquiring HIV. So there are safety concerns. There are also some immediate of impact and best use of investments now. Thanks.
Thanks, and over to you, Dr. Tina.
Thank you so much for the two questions or contributions. I'll start with the one on involvement of communities in terms of messaging, as well as how we're going to ensure that there's interaction with other prevention options. First, I want to make mention that the introduction of injectable PrEP is not going to be treated as a new program. It's going to ride on the already existing program for oral PrEP. So everything that we've done for oral PrEP, and I showed you the success of our oral PrEP program, has been due to the fact that we have involved communities in terms of demand generation of the same. So we're not going to do anything different when it comes to injectable PrEP. We use the same systems. We're just introducing